You are a great source of inspiration. So we'll try to keep on schedule today. I know some people are flying out in the evening. And what I like to do is basically have the speakers and keep time at the end of the session for question. I think it's probably going to work better that way. When you talk about neuroendocrine disease and neuroendocrine tumor, and you do a search on the NIH website, you always find the same names, basically. And the reason is because there are not that many of us who are specialized into that field and that niche. And we are very lucky today to have very prominent people in the field tackling the disease from various angles. This is the first time, actually, that I believe I meet John Buscombe, but I've heard the name John Buscombe probably for the past at least 10 years. And the reason is because Dr. Reed every day tells me how good John Buscombe is. And I know that a fair amount of you have had the opportunity to see him directly in Britain and benefit from his treatment. So without any further ado and a word, John, please.
Thank you very much. I'm not sure that my name is always taken with such positive view. I suspect sometimes it's maybe used as a little bit of a, oh no, not him again kind of thing. So first of all, can I thank Maureen, Jim and CNETs for inviting me today to come and share with you. I was asked to talk about the experience of treating neuroendocrine tumours in my unit. And I'm going to try and just give you an idea of what happens in the United Kingdom. It's not to suggest it's a perfect model, it just is a model of how we do things. So I'm going to leave Richard to talk about the technical sides of peptide therapy, and I'm going to talk a little bit more about how we organise ourselves, or how we are organised. And it's going to be a bit of a history lesson, unfortunately. So we're going to talk a little bit about how the UK health system works. The UK health system was not unique, but remains probably the last socialist system in the world, and I think probably will remain so. As other countries have gone towards insurance-based, we still remain a socialist system. What is a multidisciplinary team and what does it do? You notice I keep putting things like or not. Coordinating therapies or not coordinating therapies, as that may be. And what's it at the end like having a treatment UK style? So we've got to go back to 1823. I don't know if any of you have seen this film, very good film. It's actually got nothing to do with that. I'm just trying to find the word cholera in something that was interesting. A surgeon called William Marsden finds a young girl dying of cholera in the churchyard of St Andrew's Holborn, which is in London, central London. And at that time, you could only gain access to a hospital if you had a rich sponsor who could pay for your treatment. So William Marsden therefore opened his house to cholera patients for free. What is not recorded is what Mrs. Marsden thought of that. I don't know if you've seen this film. It's meant to be very good. I haven't seen it. Comes to 1834. Well, we'll get a bit closer to time soon, don't worry. A new young lady, the young ladies appear quite well in the beginning of this story, becomes queen when her uncle dies unexpectedly. For some reason, William Marsden knows this young lady and speaks to her about a vision of a hospital where treatment is free at the point of delivery. So patients don't have to worry about money when they come for treatment. And from that, the Royal Free Hospital is born. Now we're going to move on a century to 1940. I couldn't find an appropriate thing. This is from a television programme, not a film. As you know, 1940, Britain was surrounded on all sides, and the country was faced with two choices for Prime Minister. One was Lord Halifax, who suggested surrender, and the other one was Winston Churchill. And Winston Churchill came up with the idea of total war. And as you know, the country chose Winston Churchill. Total war was a social contract in which every man, woman and child would dedicate every effort to the defeat of Nazi Germany. The first time that all civilians would be involved in conflict. But there will be a payoff. The payoff will be that after the war, their children receive free education, and that everybody would receive free health care, paid for by taxation. So that was the foundation of our present social contract which we operate. So on the 1st of April, All Fool's Day in Britain, on 1948, the National Health Service, based on the precepts of William Marston and Queen Victoria at the Royal Free Hospital, was founded. It's a non-insurance system, there's no means testing, and the doctors who work in the service become civil servants, so their pay is not determined by productivity. Now that's quite important because it means that if, for example, we share care, there's no sharing of income, it doesn't matter, you get paid the same if you see one patient or 1,000. It's not good, of course, if you only see one. Of course, it's good for the state if you see 1,000. We have an official two-level service, primary and secondary care, and as we've already heard, that can produce problems in terms of access to secondary care. And we've heard our case histories from our patients this morning, before lunch anyway. This is now organised into local groups, which are called primary care trusts, and they're responsible covering about 250,000 to 500,000 people each. So the idea is that this is the regional area or the local area that funds the treatments. So how are cancers treated? And as we've heard, neuroendocrine tumours are a cancer. They may be slower growing cancer, but they are a cancer. Well, it was decided over the last 10 to 15 years there needed to be uniform standards. And we needed to ensure that there were particular guidelines. For example, if there was a guideline that a particular treatment worked, that this was implemented across the country. So we'd no longer have patients in different areas getting different treatments. We wanted to avoid the idea of the lone piper. Now, doctors always like to think that they know best. And of course, I know definitely best than everybody else. The problem is that they may actually be deluded. And many people who do know best often are deluded. So what we want to do is have teams of doctors looking after patients, so there can be a balanced view of what is right for that patient. And also that all options are available to us. And we had a very nice talk from Daryl about surgery, for example. And he seems to operate a really good surgical service. But of course, if you don't have a good surgeon on your team, then your patients may not be offered that service. And we'll hear about other treatments. And you need to have these doctors available to discuss the case. So two things came up. One was the multidisciplinary clinic, and the other one was the multidisciplinary team. Now, we sort of preempted that a little bit. It's a bit like Thomas in the US. Our neuroendocrine tumour lead, who's Dr. Kaplan, Martin Kaplan, whose picture is here, we really recognised very early that neuroendocrine tumours are actually quite complex tumours. And they provided complex issues in terms of diagnosis and particularly treatment. A lot of the rules that we use in oncology just don't fit. For example, symptomatic control may require different approaches, which you may then need to change as the tumour progresses or hopefully regresses. So you need to have constant review and constant change. So we set up the first multidisciplinary clinic in neuroendocrine tumours in the UK in 1995. And it consisted of a gastroenterologist, that was Dr. Martin Kaplan, an oncologist, at that time Dr. Alison Jones, an endocrinologist, that was Professor Pierre Boulou, and a nuclear medicine physician, which was myself. And we published the results of this approach in the Lancet in 1998. And from that publication was the formation of UKNet, which was the United Kingdom Neuroendocrine Tumour Network, and also the Living with Carcinoid Foundation, which is the Patients Association from the UK. I hope we had some small influence on the development of the National Cancer Strategy published in 2000. And this came across the idea that the multidisciplinary clinic should occur for all tumour types, and that patients should be reviewed in a multidisciplinary clinic or by the multidisciplinary team before any treatment or change of treatment. And though it didn't define the kind of doctors that should attend, there should be representatives from all what we call interested stakeholders. So obviously for different cancers that will be different, but for neuroendocrine tumours it's going to be quite a wide group of doctors who need to be involved. They should meet regularly. Some hospitals who don't see many neuroendocrine tumours may have a meeting once a month, but most places who have a reasonable sized clinic will have a meeting once a week. Ours, for example, is Tuesday morning. The interesting thing is that the money that is held to treat patients is held by the PCTs, and the trigger for the release of that money is that the MDT has decided on a treatment plan. So no longer should an individual doctor say, I know what's right for you. What it is a team of doctors saying, looking at the evidence, we believe this is the right option. And I think that's a big advance. And this is it goes under a very strange name. It's called the hepatobiliary pancreatic MDT, partly because we also consider pancreatic tumours in the same 5-hour meeting. And it involves a group of doctors. And the reason is because this group of doctors are involved in other tumour groups. So we have a radiation oncologist, a medical oncologist. The difference between those two, radiation oncologists tend to use radiation, obviously, treatment. Medical oncologist, chemotherapy. Gastroenterologist, because of the special problems with neuroendocrine tumours in terms of their gastrointestinal symptoms, and also expertise in endoscopy and endoscopic ultrasound. We have our specialist surgical team. We have 4 surgeons who come, who are involved. Nuclear medicine, involved with both diagnosis and therapy, as is radiology. Interventional radiology, involved in terms of embolization, or, as you'll see later on, working with nuclear medicine. The pathologist, we heard again some discussion about how these diseases need to be classified. We depend to some degree on our pathologist to help us give as much information. And we do agree with Tom that sometimes a salami effect, but you still need to have some idea what's going on. So we do need and rely on our pathologists a lot to help us. And then there are also non-medical input as well. We have our neuroendocrine tumour nurse, who some of you know, who's Philippa, who came to the Toronto meeting. And also we have palliative care nurses who are specialists in palliative care, and they can operate both in the community and in hospital, and they will have a linkage. There's also a palliative care nurse network across the whole country. So patients referred from another part of the country, they can contact that local palliative care nurse and discuss cases with them. So they don't need to go through a doctor to do that, they can actually work that. And that palliative care can go around to that patient's house and see them in their own home and work out what palliative care plan is needed. And Kaylee, our nutritionist, also was at the Toronto meeting as well. So all these people we find have input into the MDT. The neuroendocrine tumour nurse is probably the most important person in the team, because without her we would all just, as somebody once said, it'd be like herding cats. And our neuroendocrine tumour nurse holds us all together. She has a proper title, which is the Clinical Nurse Specialist in Neuroendocrine Tumours, but we all call her the net nurse. Actually, we normally call her Philippa. For the first 8 years, this role was funded entirely from charitable donations, but the last few years has been funded partly by the hospital. And she is what we call our key worker. There's a technical and legal term of a key worker. That is the contact person for patients with neuroendocrine patients. So all our neuroendocrine patients are given a business card with the telephone number of the net nurses on it. So they'll be able to phone the net nurse at any time if they have some issues. She provides a central reference point for staff and patients. So it makes us a bit lazy, really. So if you say, oh, I'd like so-and-so to have that kind of scan, can you arrange it? Then the net nurse does it for you. It's a bit cheeky, really, but it does work. The point is, you know it's going to happen, you see. Whereas if you sort of do it yourself, you sometimes forget to do it, don't you? Or you do if you're as old as I am. The net nurse has another important role, provides education and information to patients. So she will see every new set of patients. She has her own clinics that she runs 3 times a week. So she can see patients who have particularly problems with symptom control that she can deal with. She doesn't then need to refer to a doctor unless there's a more complex issue. And with the UK Neuroendocrine Tumour Network and Living for Carcinoid and with Ibsen's support, we developed an information pack and DVD which every new neuroendocrine tumour patient in the country is given, and that contains interviews with patients. And this is very much driven by the patient's group of what they want to do. And they will have local contacts for their local neuroendocrine tumour group in one half of it, and the other half is all national. To interact with patients' local oncologists and their general practitioners to obtain information for scans, etc., for MDTs. Because one of the other things we want to try and do is to avoid patients having to travel too much to clinics. So patients can be reviewed without necessarily having to travel. And of course, as many of you know, many of you have to go and see people a long distance away who have specialist knowledge. But some of the tests can be done locally. So particularly if there's a local net team, then you can work with that local net team, and that reduces the amount of inconvenience for the patient. Also, those of you who have had treatment, she helps to arrange the treatment days, etc., and sometimes needs to start or stop them or change them if there's a problem. And I'm sure, as many of you are aware, this gets a lot more complex when you're trying to get across borders and also across water, oceans, continents as well. You may or may not be aware, but we have several contracts with several countries to provide their radionuclide therapy service, so it can be quite complex. So this is the sort of in a sort of diagram what the net nurse does. So there's interactions, particularly with the patient's general practitioner, for things like the sandostatin injections and for simple blood tests. The patient doesn't need to go to a hospital for that. That can all be arranged local to where they are. Also, we still like to keep the general practitioner involved and like to educate them. So many patients who may have changed symptoms, we try to get the general practitioner who's local, who can actually be much easier to see the patient initially, for them to deal with them. And not say, oh, it's too complex, it's too difficult. And I think if you can get a good relationship with your own personal family doctor, that is actually a very good boon, because they can provide a lot of very simple care. If they're not sure, they can phone the net nurse, and if she can't answer it, she'll ask one of us. We'll phone the GP, and a lot of problems can be sorted out without the patient having to travel. Where we're offering a service to other oncologists, we will also interact with them and their local net team and their local net nurse. So, for example, a net nurse in Liverpool might discuss a patient who's coming down with our net nurse, and they'll have a lot of information about that patient, about their medical condition, about their social issues, about their fears, their worries, etc. And also, she interacts with the patient's PCT. Now, that's quite important for us because that's where the money comes from. So that enables us to generate the money to keep the service running. Well, where can it all go wrong? It all sounds perfect, doesn't it? And the problem is, with any kind of bureaucracy, things can go wrong. One of the problems is that nuclear medicine is very heavily legislated. We are the most heavily legislated medical specialty in the United Kingdom. Almost anybody, it appears, can come in and close us down at a moment's notice. We need approvals to do almost anything, and you need to get licenses, and all these licenses have inspectors and inspection visits and all sorts of things. At the moment, we only have a limited number of beds that we can use, and these are registered by law, and at the moment we have 4. Hopefully by the end of the month we'll have 5. When we're treating with our main radionuclide therapy, which is Y-90 DOTATATE, we have to obtain the product. The DOTATATE comes from Poland, and we found that they have a good and consistent supply, and at the moment they seem to be providing the best service. That may change. The actual Yttrium-90 either comes from Canada or from the US. Again, you can get Y-90 from everywhere else, but the cheapest and the most reliable sources we found are, for us, from Canada and the US, remembering that we sit on the very edge of Europe, and it seems sometimes easier to get a plane over from Boston than to get one from Holland. And of course, the problem is with anything that's shipped in, particularly radioactive, because any radioactive substances has to go to a place called Coventry, which is in the middle of nowhere, where they are secured to ensure that terrorists do not obtain our stuff, which is great when you find that they then lose it. And you say, well, how do you know the terrorists haven't got it? Oh, we don't know, we don't have the paperwork. Yeah. Do you remember, have you ever seen, what's his name? Indiana Jones, the first one. You know where they hide the Ark of the Covenant, that massive warehouse? Well, that's what Coventry looks like. And your little box of yttrium is in that massive warehouse, and somewhere they have to find it, you know. And this can be delayed by snow, fog, and strikes, particularly snow at Boston Airport. You thought the Boston Airport could deal with snow, wouldn't you? Never mind. They seem to have issues with takeoffs during snow. And when it all goes wrong, the net nurse has to try and sort it all out. Obviously, you'll be pleased to know that if we know you're coming across the Atlantic, you will be a priority. And I may not be able to guarantee that you'll be treated on a particular day or time, but I will almost, I mustn't say this because I'll probably it won't go wrong next time, I will make my absolute most to make sure that you don't go back without being treated. Okay, so even if there's a hitch, priority is given those who have to travel the longest distance, obviously. So what happens in the UK? Well, I've tried to do a sort of little map of Britain and the various treatments. So MIBG therapy, which is still used, we still do some MIBG therapies, is more widely distributed with centres in Scotland, Northern Ireland, northwest, the northeast, and the south of England. And this is the number of patients treated over that last 10 years. So many centres doing a few patients a year. We are the largest centre. We have about 1,200 patients on our books. But some of the other centres, for example, Belfast and Glasgow, have 300 or 400 patients on their books. The treatment will depend on a series of things such as, do they have trained staff available? Can they get all these licenses that are required? And that's a big problem, these licenses. It can be very difficult and very expensive to obtain them. London I've actually done as a separate map. I haven't quite managed to fit the geography in right, because they actually are much more in the centre of London. But London, this is not London, Ontario, by the way, just in case you're wondering. This is the other one. This is London. I notice I'm London Uck here, so this is London Uck as against London On. There are several centres in London that offer treatment or have offered treatment. Barts used to do some treatments. That's in northeast London. They don't do anymore. Guys do some treatments with MIBG, and may have just they're about to start their first lutate treatment. King's College London, which is in the south of London, has done basically all the treatments. At the moment, they're concentrating on some lutate treatments. University College Hospital in central London does MIBG and the lutate treatments. We have the biggest group, but we tend to concentrate mainly on MIBG or the yttrium ultratate. And we have treatment slots for about 32 patients a year. One of the problems is, unless you manufacture the product yourself, which we're the only centre to do so in London, other centres just have a limited number of deliveries each week or each year. So, for example, the Royal Marsden Hospital are allowed to treat 3 patients a year total and no more. So that is a big disadvantage for them. So it is actually, unfortunately, one of the problems that we have with these treatments is it tends to be where people can do things. And they tend to be then concentrated in particular centres where they've built the expertise. Okay, so there are a few other things that happen to you in the United Kingdom. How long do you stay in hospital? Well, there's a whole nother set of legislation that governs this. There's called the MARS, which has got nothing to do with a planet or little chocolate bars, but it's the Medical Application of Radionuclide Substances Act, 1966. That one, if I contravene that one, I think it's a 6-year prison sentence. And the Environment Agency fortunately cannot send me to prison, but they can fine the hospital $2 million Canadian. which would have been all right except for the fact, unfortunately, not me, but the radiotherapist lost some cesium once, so we've already been fined 2 million Canadian dollars, so the next fine is 5 million Canadian dollars. So we have to be pretty careful on that one. And generally the idea is that if you received a radioactive treatment, then you're not perceived as a threat. If you have MIBG, you'll be in for 5 to 7 nights, Y-90 1 night, lutetium 177 2 to 4 nights. Those of you who've been to the Royal Free Hospital will realise this is not a luxury hotel. And the food was once voted the worst in London. Actually, no, it was voted the worst in England, actually. Which, if you think about it, for England is quite an achievement, really. I mean, there's a lot of competition for worse food in England, isn't there? But you get a single room with a bathroom. Now, for those of you in North America, that sounds unusual, but in America, in the United Kingdom, you're normally on a ward with 35 other people with swine flu, so to get your own room is pretty good. So this is one of our rooms. It's on the ward 8 East, but our new ward will be 3 floors higher at 11 East. For those who are interested, the new ward will have a very good view of the Emirates Stadium. So if you like watching Arsenal play soccer, that might be a possibility. If you've got a pair of good but strong binoculars. We use an infusion pump system. If you're using MIBG, we have to give potassium iodide and antiemetics whilst we're doing the treatment. For the Y-90 or lutetium octretate, though we don't do the lutetium octretate at the moment, but the treatments are very similar in terms of how they're given. But also we give amino acids and fluids and antiemetics to protect the kidneys from the radiation dose. But Richard will give you more information on that, I suspect. And pain relief as required. The treatment isn't painful, but of course you may have pain for other reasons, and therefore you need to have that available. We use these lead shields just to try and stop people walking out and get themselves contaminated. It's really surface contamination we're worried about. And each of the doors has a panel on with a radioactive sign. But we don't like pinning people in too much to the rooms. The rooms have got a bit of, you can see out and people can come and talk to you. So it's not too prison-like. We also do some imaging, normally the day after the therapy, to try and confirm localization at the site of tumour. This, for example, is a CT scan of a patient with liver tumour. There's a DOTATATE PET study showing uptake in the tumour. And then you have, we don't do the DOTATATE PETs ourselves. We get them done at University College Hospital, which is one of the few places in the world that can do it at the moment. Hopefully, again, that will change in years to come. And at the below, you can see we do a therapy scan. You can't get very good pictures with Y-90, but you get a fairly good uptake, and you can see that there's been a significant reduction in the amount of active tumour between treatments. Now, one of the things that Thomas said earlier on today was about how we monitor treatment. And I think one of the disappointments is the main way that we're expected to monitor treatment is with CT. And CT probably isn't very good for monitoring neuroendocrine tumours. And this can be quite depressing. If you've gone and had all these treatments and the CT doesn't change very much, but you think, well, I'm feeling a bit better, my symptoms are less, I've got a bit more energy, but then you go and have your CT done, it doesn't show any change. Can I just say now, and I think that Richard would agree with me, and hopefully you would as well, Jean-Luc, is that CT is not very good at monitoring these patients. This is an example of a patient treated in Poland, and this is part of a paper we've just published between Poland and ourselves. And you can see here a patient who has lots of lesions within the liver, and all those sort of ring lesions that look a bit like sort of lifesaver sweets, that's the tumour. When we did the scan 6 months after the last treatment, okay, so 6 months after the last, not during, 6 months after the beginning of treatment, 6 months after the last treatment, there's a little bit of improvement, but it's not a lot better. But the patient felt a lot better. We then scanned the patient 6 months later. They've had no treatment in the meanwhile. And you can see that the CT has further improved. Now, I think the thing is you often get very delayed changes on CT. So the only reason that we do a CT now is just to make sure the tumour is not getting bigger. I think if the tumour gets bigger or there's more tumour, then it's clear the treatment's not working and it might not be worth continuing it. But if the tumour is the same size, that doesn't mean to say the treatment's not working. I've had lots of patients where the tumour has not changed at all, but we haven't had to retreat them for years. They've been perfectly well, climbing mountains, cycling around New Zealand, doing what they want to do. So please do not be upset by CT scans. They are really only a guide if things are getting worse. And we really must sort of emphasize that. And when you start to look at the other measurements, things like the hormone production, sometimes the chromogranins, but I think the best question is, how are you feeling? I think that tells you a lot more than CTs do. And we can clearly show patients who feel better live longer. So if you feel better, it's working. One little thing that we've done, and I think Rich may show a bit more about this, is that we've also helped to pioneer one of the ideas of intra-arterial therapies. A lot of patients have, as you know, have quite a lot of tumour in the liver. And we've always been treating, well not always, but for the last 25 years in nuclear medicine at the Royal Free, we've always been treating liver tumours by injecting radiopharmaceuticals into the liver. We started off with Lepardol, we now use these Y-90 Surspheres we heard earlier. Not for neuroendocrine tumours, but other tumour types. But we thought, well, if your tumour's in the liver, you might get an added bonus by just injecting the peptide directly into the liver. Okay, so what we do is that we get one of our radiological colleagues to put a catheter into the hepatic artery. We heard earlier about the portal vein being one of the arteries that supplies the liver. The other one is the hepatic artery. And then you can inject the Y-90 peptide directly into that. And we published our results in radiology a few years back. But here we have a very interesting controlled trial of a patient. Now, everybody likes a controlled trial, but this is controlling an individual patient. This is a patient who has almost the whole of the right lobe of their liver completely replaced by tumour. And there's also a small lesion. I'm going to point it here. There's a small lesion in the left lobe, sort of in the midline. Oh, there we are. So that's the small left lobe, and that's the big right lobe. After a single, in those days we had just had lanreotide, we didn't have the good stuff we got now, which is the octreottate. After a single injection of the lanreotide intra-arterially, the tumour on the right has completely shrunken down. This is only about 10 weeks later. But interestingly, the tumour we didn't treat, because we only treated the right side of the liver, on the left side, has actually grown slightly, showing a controlled trial of treatment versus non-treatment. We obviously went on and treated the left side in the second treatment. But it does show that this method works. So sometimes if patients have a lot of liver disease, we'll offer this as either one of the three main treatments we give or as an added bonus, or sometimes do 2 intra-arterial, 2 intravenous. And this helps to try and give an extra boost to the liver. And it does seem to work well. It's a bit uncomfortable on the day because obviously they need to actually get into an artery, so they have to put a puncture into the femoral artery, and you have to keep still that day. But by next morning, it's fine, and it's no worse than any of the other treatments. So an added bonus that sometimes can give us an added advantage. So in summary, we have to work within the confines of the system that we work in. There really is no private facilities in the United Kingdom capable of this type of complexity. Private medicine in Britain is okay if you just have a common disease. If you have anything serious, you need to rely on the state, because only the state has the facilities to do serious, complex treatments. So you're going to have to come in and fit in with our systems, if you know what I mean. Now, there are good and bad in that. There's good in that there's safeguards, and there's bad that it's sometimes a bit slow. And that's always the problem with the bureaucracy. We try to work in a coordinated way through our MDT, and the net nurse is our key worker. She's the person that holds it all together. And you can imagine that the 2 weeks she's off on holiday, yes, it doesn't always hold together very well. Yes, that's life. I think it's best when treatments are done in specialist facilities, because you're dealing with a team of people who know what they're doing, who can cope with any problems, and I think it will enable you as patients to have confidence that we know what we're doing. And of the centres in the UK, we're obviously the biggest, but we're not the only one. And there are other centres in the UK, and there are other big centres, bigger than us, in Europe. But I think the important thing is we learnt to work together and not to compete. Thank you. Yeah, absolutely.